to another collaborative meeting between PATS and GSK. The topic of today is challenges of managing respiratory disease in COVID-19 pandemic in Africa. And this is the GSK disclaimer that this is a medical educational program supported by GSK in response to the request received from PATS. GSK does not have any approved medication or vaccine to treat or prevent COVID-19. The content is developed independently by the external experts. The information shared during this broadcast represents the views and opinions of the speakers and does not necessarily represent the views or opinions of GSK. The broadcast does not constitute an endorsement by GSK of the speaker's personal views and opinions. So I'd like to hand over the meeting to the patron and Dr. Luch. So kindly take over. Thank you.
Thank you, Josephine. Good evening or good afternoon, wherever you may be in Africa. Let me take this opportunity to welcome you, and first and foremost, to thank GSK for hosting this second webinar on the challenges of managing respiratory diseases in COVID-19 pandemic in Africa. We're truly grateful. My name is Dr. Joseph Alwaj. I'm the president of the Pan-African Thoracic Society and your facilitator today. We are having very good panelists with us here today, and the topics are very good. Basic housekeeping, first and foremost, all the participants are muted automatically because of the number. The panelists will mute themselves until they are speaking. We advise you to write your question on the Q&A column, not on the chat. If you do write them on the chat, they may not be attended to. I'd like to thank you for tuning in, and I'd like us to just go through the agenda. We have 3 items on the agenda in the next 1 hour and a half. First is managing pneumonia during the COVID pandemic in Africa. And secondly, critical care in COVID pandemic in Africa. And lastly, interesting session, working behind masks. How is it affecting mental status of the patients, healthcare workers, and family, which is becoming equally important. So without wasting long time, it is my great pleasure to introduce the first speaker, Professor Feldman, who is a distinguished professor of pulmonology, Faculty of Health Sciences, University of Westwater, Johannesburg, South Africa. His career spanned many decades. He's had a lot of work on acquired pneumonia, a lot of lectures, and he's well known all over the world. Just last week, I was listening to his lecture, another webinar on vaccination in adults, which was very equally interesting and inspiring. And I'm sure he's carried the same inspiration with us here today. Professor Feldman, can I welcome you to the podium?
Thank you very much for that kind introduction, Dr. Alut, and thank you very much to you and to PATS and the organizers and GSK for inviting me to participate in this very important meeting. My area of interest is community-acquired pneumonia, and of course, COVID-19 commonly presents as a community-acquired pneumonia. I'm going to talk to you about the challenges that we face in Africa in differentiating and handling straightforward pneumonia from COVID-19 with the challenges that there are. This is the overview of my talk. I'm not going to spend a lot of time with this. I'll introduce what the coronavirus is and how much of there is of this in the world and in Africa. Talk a tiny bit about the management, and then go on to the challenges we face in Africa and how we should manage CAP during the COVID-19 pandemic. So I think most of you will know all the first of the beginning slides. Coronavirus is a large family of viruses that cause illness in animals or humans. They are truly a zoonotic infection in terms of what we're talking about today. Among the human causes, of respiratory illness that coronavirus causes. We have the common cold, and we have the original SARS and MERS outbreaks, and then what we are faced with now, the SARS-CoV-2 or COVID-19 infection, as we call it. Now, this is one of the maps from the WHO. It's a situation report 113, so that's a day or two ago. And one can see that the darker the brown colors are, the more there is in terms of infection in the different parts of the world. And as we can see in Africa, and certainly in sub-Saharan Africa, there are areas with COVID infection of varying degrees. There are very few areas of the world that have remained without reported cases. This is truly a pandemic involving almost every country. This is the sort of timeline of COVID-19. It is a little old, but I thought it was interesting because if you start at the top left-hand corner in December 2019, that's when the Wuhan outbreak was full-blown and became available. The information started becoming available about COVID-19. And then as we move along into January and then turn the corner into February, we can see that on the 15th of February, the first case was seen in Africa, and that was in Egypt. And then it spread further into sub-Saharan Africa. 28th of February, we had cases in Nigeria. And I think you know how the evolution of the pandemic has been since then. This is what the cumulative number of cases look like in Africa, in the WHO Africa region. You could see up to the 5th of May 2020, the different regions of Africa. There's quite a considerable amount in Northern Africa, which obviously represents a large part of Africa. But you could see that all the regions, Eastern, Central, and Southern, etc., are infected with the virus. This is the daily numbers up until the 12th of May of the different countries. It doesn't project very well because it comes directly from the publication, but just to point out to you that almost all the countries have, in fact, cases of varying degrees. And this is just also an older slide. These days seem to age things, but this is 28th of April, and one can see South Africa at the top left, and you could see Guinea in the bottom right, and you could see the varying incidences or case fatality rates of the COVID-19 outbreak. It varies, the case fatality rate, 12.6 in Guinea, up to about 12% in Algeria. But obviously there are issues in terms of reporting this and how much testing and recognition of the organism there is. So this is the topic of my talk, challenges in Africa regarding management of CAP. So the biggest issue is, as COVID is primarily a respiratory illness, although as you know, I'm sure it involves other organs in the body, many other organs in the body, differentiating COVID-19 from usual community-acquired pneumonia, or possibly even HIV-infected individuals with opportunistic infections is not easy. The diagnosis is firmly based on the use of nasopharyngeal swabs, and so the availability of diagnostic testing, even in some of the better off countries in Africa, has been an issue. Availability of drugs, there are a myriad of drugs, I'm sure many of you are familiar with, that are available for treatment. Whether they work or not is still being studied in many cases, but many of the drugs are not routinely available in all areas. There's also a lot of lack of evidence for many of the treatments, and as the evolution of treatments and treatment studies is evolving, the scientific evidence changes from day to day. There are limitations in delivery, for example, of supplemental oxygen. It's critical. There's a paucity of critical care capacity in terms of ventilators and staff. The ethical issues in terms of ICU access, the shortage of all types of healthcare workers that are needed during this pandemic. Many of the African countries have limited access to clinical trials, which are allowing the use of various different drugs and vaccines in different areas, although we're fortunate enough in many areas to have these studies. Ultimately, the equitable distribution of any COVID treatments or vaccines that come about is an issue that we would need to keep our eyes upon, and rather than the well-off areas claiming all these treatments and vaccines, we need to have distribution in our region as well. And then an issue is potential stigma attached to having had the infection. Now, many of the models of care come from high-income settings, and they're likely to be inappropriate for situations or areas where resources are limited. You've got the two inverse pyramids where the majority of the patients present with mild infections, and that can clearly be handled with relatively basic clinical interventions. But at the top of the one and the bottom of the other pyramid are the patients who receive a critical diagnosis, who need advanced critical care and a myriad of support and drug support. And here, the availability of resources in Africa is relatively limited. So starting off, how do we manage the whole situation? I think the important thing is that anybody should practice the usual recommended hygiene methodologies. So one of the things that we have on the top left is social distancing and the use of masks. On the right is screening individuals for pyrexia. On the left is washing your hands with soap and water or alcohol rubs. Soap and water does very well because the detergent action of the soaps actually dismantle the structure of the virus. That's very good. Cough hygiene is also very important, coughing into one's elbow or into tissues and so on. And I think that's an important place to start. Prevention, as they say, is better than cure, and this could help us limit the spread of infection. Masks are very important. A lot is not known about masks, and there are different kinds of medical masks. There's the medical masks, such as surgical masks and things like that, which are used to prevent the spread of droplet infection from infected persons, and also to spread a potential contamination of the environment by droplets. Non-medical masks is what the people in the street are requested to wear. Cloth masks made from various different self-made or other face mask covers, for example. They're not standardized. They're not intended for use in healthcare settings by health professionals or home care cases, but literally as part of the social distancing procedure. And then there are the respirators, the N95 masks and other masks. Those are used to protect healthcare workers from exposure. And it's important for differentiation to occur because there are limited resources and limited numbers of the respirator type masks which are required in the healthcare situation. And it's also important to make sure people wear their masks correctly. One has seen examples with the people wearing it on their neck, particularly we've seen individuals being interviewed on television doing that kind of thing, wearing them not covering their nose or wearing them not covering their mouth, not recommended in children, and top left hand is the best way to wear them. So let's go on to diagnosing pneumonia, whether this is a usual pneumonia, an opportunistic infection, or COVID. So it's possible that physical examination may not be possible and that the individual may be phoning through, and one needs other ways of making an objective diagnosis if possible. So the clinical diagnosis of CAP, which of any cause in an adult, can be informed by clinical signs which patients themselves could talk to. Temperature above 38, a respiratory rate above 20 breaths per minute, a heart rate above 100 breaths per minute, and new confusion. Remember, of course, that at this time, we're talking about adult patients. Things are very different in pediatrics. But patients should be able to report on those. What about severe pneumonia? There are a number of symptoms and signs that could help to identify, even at a distance, those with more severe illness. So severe shortness of breath at rest, for example, coughing up blood, blue lips or face, cold and clammy and pale skin, collapse or fainting, and so on. And these obviously are things that could even be looked at from a distance. Now, how do you differentiate viral COVID-19 pneumonia from bacterial pneumonia? And the answer is that it's very, very difficult to determine, particularly in primary care and particularly during these remote consultations. However, COVID-19 becomes more prevalent as it becomes more prevalent in the community. Patients with pneumonia symptoms are more likely to have COVID than a community-acquired pneumonia, and it's more likely to be present with the following. And clearly there have been case descriptions distributed by the African CDC or Union and other societies. Typically, COVID presents with symptoms for about a week. There's often the typical flu-like symptoms, severe muscle pain, myalgia. A characteristic symptom is sudden loss of sense of smell or taste. The patient is breathless with no pleuritic pain. And clearly, if there's been a person who's had known or suspected COVID-19 exposure, such as a household or a workplace contact. Now, a bacterial cause is more likely if the patient becomes rapidly unwell after only a few days of symptoms. They typically don't have the flu-like symptoms. There's not a history then of the typical COVID-19 symptoms. If they have pleuritic pain and they have purulent sputum, more likely to be a community-acquired pneumonia. What is the differential and diagnosis? And this is important, particularly as we go into the winter season in the Southern Hemisphere. So influenza, obviously remembering that the seasonality is different in the Northern and Southern Hemisphere. And so around the equator, the differentiation is not quite as distinct. It could be conventional or so-called atypical bacterial pneumonias. And particularly in HIV individuals who are immunocompromised, it could be opportunistic infections such as pneumocystis jirovecii pneumonia. So it's recommended that the following samples are taken from patients: full blood count, differential count, blood cultures, the nasopharyngeal swabs or aspirates or oropharyngeal swabs, both for the detection of viral pathogens, including COVID-19 and possibly atypical pathogens. Chest radiology, and I'll talk a little bit about this in a slide or two. And obviously, in our setting where TB is so endemic, a sputum not only for culture and sensitivity, but also for detection of tuberculosis with whatever technique is available. Certainly, the African Union and the African CDC have indicated that their idea is that we need to be able to be doing COVID-19 testing. It's interesting that this has been an issue in many, many countries, including highly developed countries, where there hasn't been adequate testing or adequate rapidity of testing. And I came across an article, these articles come across your desk almost daily, of a company that are trying to develop a reusable test kit, which I found very interesting. So should you admit the patient to hospital or not? That depends on the severity of the pneumonia, the benefits, risks, and disadvantages, because they are in relationship to hospital admission, the care that can be offered at home, whether it would be adequate, patient's wishes, and then obviously service delivery issues and local resource issues. So any patient who fulfills the criteria for COVID-19 patient should be quickly triaged in terms of severity. And in the emergency department, routine emergency department triage systems may be used. In the context of COVID-19, triaging is essential because of the need often for supportive therapy, oxygen supplementation, implications of whether or not the patient can go home, and also to protect the hospital members of staff. I came across this from the Fleischner Society, which I thought was very interesting. What about radiology? Well, clearly, radiology is an area where patients may congregate for the x-rays and where radiologists may come into contact with potentially infected patients. And what they're saying is that imaging is not indicated in patients with suspected COVID and mild clinical features unless they're at risk for severe disease progression. Imaging is indicated in a COVID-19 patient who has worsening respiratory status, and I think it's important that in resource-constrained environment, imaging is indicated for medical triage of patients with suspected COVID-19 who present with moderate or severe clinical features and a high pretest probability of the disease. This was developed by the National Institute of Communicable Diseases in Johannesburg, in South Africa. These are the criteria for home management. I won't go through them, but they indicate that the patient has clinical features of mild disease, that they're able to self-isolate at home, and they're not in one of the high-risk groups, younger individuals, and no comorbid or debilitating conditions. So how do we treat the COVID-19 patient? Well, it's caused by a virus. Antibiotics are ineffective, and it's recommended that you do not offer an antibiotic for the treatment or prevention of pneumonia if COVID-19 is likely to be the cause and if the symptoms are mild. And obviously, without going into it, we know the side effects of inappropriate antibiotic use. How to treat a usual, as I called it, pneumonia. Offer an antibiotic for the treatment of the pneumonia in people who can or wish to be treated in the community. If it's likely bacterial, or if it's unclear whether the cause is bacterial or viral and the symptoms are concerning, or any of the high-risk groups with underlying comorbidity and a history of severe illness should be considered for antibiotic therapy. Whether the patient fits the appropriate clinical syndrome, consider treatment for other pathogens, so conventional community-acquired pneumonia. I've put there, for example, amoxicillin clavulanate, as per the South African guidelines. You'll allow me to punt our South African guidelines. Atypical pathogens, macrolide, influenza, the use of agents such as oseltamivir according to the directions, and obviously PCP in the correct situation if it's suspected. Now, in terms of additional supportive therapy, because Guy Richards will go on to the critically ill patient, first thing, of course, in a patient with COVID-19 is to give supplemental oxygen immediately to patients with lower oxygen saturation. And the target should be a saturation above 90% in non-pregnant adults and higher, interestingly, in pregnant patients is recommended. So the green are the big issues. Use conservative fluid management in patients presenting with a severe acute respiratory infection when there's no evidence of shock, because aggressive fluid resuscitation may worsen oxygenation. If clinical suspicion for co-infection exists, consider antimicrobials, but really in the more severely ill cases, and closely monitor patients for clinical deterioration. What's interesting, and this has come out of South Africa and it's come out of the African CDC and the WHO, it has been recommended that individuals should not routinely be given systemic corticosteroids for the treatment of COVID-19 unless there are other indications for this for the giving of steroids, such as a patient with an acute exacerbation of asthma or chronic obstructive pulmonary disease, and so on. And it goes through the studies. I don't know that we've seen the last line about corticosteroids in COVID-19. We certainly do use corticosteroids in severe community-acquired pneumonia in patients requiring ICU admission, and there has been some concern of systemic corticosteroids in influenza infections. But at the current time, the routine recommendation is not to use them unless for another reason. And also coming out of South Africa, as well as the African Union, WHO, the indication, certainly in a resource-constrained environment, that there's no current evidence from randomized controlled trials to recommend any specific anti-COVID-2 agent. So this is the statement that came out of the African Union CDC statement of medications to treat COVID-19, and there's no recommendation for any of the additional multiple agents. COVID-19 patients can be discharged from home, provided they meet all the following criteria. There are no medical indications for admission. Symptoms have improved. Patients had 2 consecutive negative tests, and they could discharge home provided they meet all of those criteria. So what the WHO says is that the Africa region should be reinforcing emergency responses against COVID-19 in Africa. If we don't and we fall short, we are likely to see somewhere between 83 to 190,000 people dying in Africa from COVID-19, with almost 45 million people infected. Clearly, the African Union and the WHO has been suggesting that we need to be ramping up testing for COVID-19, which could save lives. And this is my conclusion slide. It's not necessarily meant to be what we would recommend, but I will go through it. Why I've put it in is that the authors are Josh Meckley and Grant Waterer, who are the co-authors of the new Infectious Disease Society of America and American Thoracic Society guideline that has just come out on the management of ordinary community-acquired pneumonia. When the guideline was developed, there was no COVID-19, but they've come out with this new update talking about principles of management of patients in pneumonia, with pneumonia in patients with COVID-19. Empiric coverage for bacterial pathogens is recommended in patients with CAP without confirmed COVID-19, but it's not required for all patients with confirmed COVID-19 related pneumonia, which we agree with. The relevant bacterial pathogens in patients with pneumonia and COVID-19 are likely the same as other patients with pneumonia, and therefore we should follow our guideline recommendations for antibiotics. Testing for bacterial pathogens with sputum and blood cultures and so on is useful for multi-drug resistant pathogens, and in Africa, particularly for tuberculosis. We would not recommend routinely using procalcitonin, although those authors do. And on the basis of current data, the authors of the CAP guidelines say that immunomodulatory therapy is not recommended as a routine adjunctive treatment in patients with pneumonia out of the critical care situation. So once again, I'd like to thank you all for joining us for this webinar, and thank Dr. Aluch for having invited me to participate.
Thank you very much, Professor Feldman. Excellent talk, as always. And thank you very much for sparing a moment from your very busy schedule. I know you're running off for another one. We thank you very much, and we hope to have you again in the future. I will now go to the next speaker, who is going to talk equally important and critical subject, that is critical management of COVID-19 in hospital. And we have none other than one of our top critical specialists, Professor Guy Richards, who's been a professor of critical care medicine at the University of Witwatersrand, and is known for many lectures locally and internationally, and above all, has visited a lot and taught a lot of people. It's always a pleasure to have you guys. Over to you.
Yeah, thank you, Joseph. It's a pleasure to join you as well. And also thanks to PATS and GSK for arranging this this meeting. I think it's a particularly interesting one, and nice to hear other people's opinions as well. So if I can just be given access to my slides, they're not as yet moving. There we go. So as Charles has actually said, the situation has expanded rapidly. And if you actually have a look, that as a shorter time ago as on the 1st of March, there were only 107,000 cases, and now there are 4 million cases and 304,000 deaths that we're actually dealing with as well. The vast majority are mild, 98% of the active cases, and the serious ones represent about 2% of the total number. Now, of course, this number decreases as testing actually increases, because we find a large number of asymptomatic or mildly symptomatic patients that are added to the total, which means that those that actually have severe disease are actually very few. And lockdown, in fact, has been the pattern all over the world. France went into lockdown on the 17th of March, and using models, they estimated that 3.6% of their patients were hospitalized and 0.7% of those will die. That represented 0.001% if you were less than 20 years of age, and up to 10% if you were more than 80 years of age. And that, of course, has been the pattern throughout, has been the increasing mortality at older age groups. Interestingly as well, at all age groups, men are more likely to be hospitalized, enter ICU and die. And the lockdown reduced the reproductive number, the R0, from 2.9 down to 0.67. Now, that's a 77% reduction. And of course, that's been very important because it allowed the hospitals to prepare themselves for an influx of patients. Once one lifts the lockdown, then we're going to see dramatic increases or surge increases occurring as well. By 11th of the 5th, on easing the lockdown, they projected that 2.8 million people, that's 4.4% of the population, will have been infected. And of course, we need to have large numbers infected in order to develop herd immunity as well. Lockdown alone is insufficient to avoid a second wave unless we get sufficient numbers infected and to have herd immunity as well. So we've heard something about the phases of the illness. We have an upper respiratory tract phase, that is the initial one. Then we have a lower respiratory tract phase, which is the pneumonic or pulmonary phase. And then we have a viremic phase, the hyperinflammatory phase, which is associated with a real increase in the mortality of the patients that actually get to that point. And of course, decreasing numbers will get these phases as you go to the right. So the vast majority are upper respiratory, less of them are going to be lower respiratory, and even less are going to be in the hyperinflammatory response, which is associated with dramatic increase in inflammatory markers and CRP and interleukin-6 and D-dimers, etc., that we will actually see. So if we're looking at the patients who actually are hospitalized, most of them would be patients who are come in because of hypoxemia, and the hypoxemia would be mainly related to the onset of pneumonia. And these are x-rays and then a CT scan looking at a patient, a 71-year-old male, with progression that occurred over 6 days. And as you can see, became progressively hypoxemic with worse and worse gases, and then required to be intubated eventually. And that patient didn't make it. One of the problems, of course, also is that there is diffuse intravascular coagulopathy. So not only do you actually get a pneumonia, but you also show microvascular thrombosis in the lungs and hemorrhage and extensive alveolar and interstitial inflammation. And this shares features with the macrophage activation syndrome, or HLH, which is the lymphocytic your hemophagocytic lymphohistiocytosis, or the macrophage activation syndrome. And we get markedly increased D-dimers because that's from the pulmonary vascular bed thrombosis, and then your body trying to dissolve those clots with fibrinolysis. And then we get elevated cardiac enzymes from right ventricular strain, as severe and early manifestations of the pulmonary intravascular coagulopathy. The risk factors for mortality, I've mentioned some of those, but age, male sex, cardiovascular disease, obesity, diabetes, possibly race, although that hasn't been confirmed. In the UK, patients from minority groups or doctors from minority groups were more likely to have severe disease. There may be something in that. Preliminary reports showed no increase in propensity to acquire COVID-19 in well-controlled asthmatics, not on oral steroids, patients with COPD, HIV, or on biologics or receiving chemotherapy. There may well be a relationship to being on oral corticosteroids, though, in terms of the mortality. Some of the biochemical markers that are associated with mortality on the left is a D-dimer. As the D-dimer rises, and we're indicating this microvascular pulmonary thrombosis, so the mortality increases as well. If you look on the right-hand panel, lymphocyte count, as that depletes or goes lower, there is an increased mortality or decreased survival there as well. Perhaps the most important marker of the hyperinflammatory state and outcome, in fact, is the interleukin-6. And in this study of 40 patients, 32.5 required mechanical ventilation, and they didn't differ with regard to age, comorbidities, x-rays, respiratory rates, or the quick SOFA score. However, an elevated IL-6 was strongly associated with mechanical ventilation, and that p-value is 0.00001.12, and a level of greater than 80 picograms per mil predicted the development of respiratory failure with a high accuracy, and again with a very high p-value and an area under the curve that was very impressive as well. So, and that was with a rate 22 times those greater than those with the lower levels. The thrombotic episodes, 449 severe COVID-19 patients, 99 received low molecular weight heparin for 7 days. Multivariate analysis showed that D-dimer, prothrombin time, and age were positively related, and platelet count negatively correlated with 28-day mortality. So as those factors increase, D-dimer, prothrombin time, and age, you would increase your 28-day mortality. And low molecular weight heparin was only of benefit in those that had the most extensive thrombosis. In other words, they had sepsis-induced coagulopathy score. That's a score whereby greater than 4 indicates severe thrombosis. And there you could see that the mortality was 40% in those that received heparin versus those that didn't, who had a mortality of 64%. Or a D-dimer that was more than 6-fold above the upper limit of normal. And there you could see that low molecular weight heparin decreased mortality from 52 down to 32.8%. In patients on antiviral treatment, low molecular weight heparin reduced hypercoagulability, inhibited IL-6 and its biological activity, and potentially blocked the cytokine storm. Cardiac disease, obviously also a very important factor in terms of mortality. Of 187 COVID patients, 23% died, 35% had underlying cardiovascular disease, and that was hypertension and or coronary heart disease. And of these, 27.8 had an elevated troponin. If you looked at those that had no cardiovascular disease and a normal troponin, the mortality was 7.6%. If you looked at those with cardiovascular disease and a normal troponin, it was 13.3%. And if you looked at those with no cardiovascular disease but an elevated troponin, mortality was 37%. And it was 69% in those that had both the cardiovascular disease and elevated troponin at the same time. But the good old Apache score is also a very good way to actually assess what your mortality is likely to be. 154 patients enrolled, 52 of those patients died. The mean Apache 2 was 23 in the non-survivors and 10 in the survivors. And using a cutoff of 17, the Apache 2 predicted death with a sensitivity of 96% and a specificity of 86. So probably the best way of assessing mortality. So we've heard about from Charles something about the early supportive therapy and monitoring of the patients as well. First of all, obviously, please wear appropriate IPC. I'm not going to go through all of the parameters of IPC. I think that that's a talk on its own, and we're talking about patient management in particular. Importantly, conservative fluid management. Don't make your patients edematous. Even in those that have shock, Don't fill them up with fluids and make them edematous. We have to give empirical antimicrobials until we've determined that it is COVID and it's not actually a bacterial pneumonia. But we de-escalate rapidly if the procalcitonin is down, and I would recommend using it in patients with pneumonia in the hospital. Closely monitor for clinical deterioration, supplemental oxygen immediately as required, and we would use high-flow nasal oxygen, NIV possibly, and we might need to intubate the patients as well. So from a ventilatory support point of view, nasal cannula initially. Your high-flow nasal cannula is beneficial. It provides up to 60 liters per minute and gives you approximately 100% oxygen, or FiO2 The aerosolization is similar to that of the nasal cannula using the high flow at 6 liters per minute and even at 30 and 60 liters per minute. So, sorry, nasal cannula at 6 and high flow at 30 or 60 has similar aerosolization. NIV, well, we're not definitely sure about that. There was a high treatment failure rate in patients with MERS-CoV. Patients do retain some control over respiration, and very large tidal volumes may cause some self-inflicted lung injury if ARDS develops. And given the unclear benefit, NIV is probably of limited value. If you get to the point where your high flow is no longer working or a rebreather mask is no longer working, then you probably need to ventilate your patients there. We do prone our patients even pre-intubation. It does improve VQ matching and reduces mortality versus supine. And observational studies of viral ARDS with COVID-19 provide support for a trial of awake proning and high-flow nasal cannula at the same time. Just of interest, it doesn't work particularly well in obese patients. They're not able to tolerate it. And in addition to that, not all patients will improve when put in the prone position, but certainly is worth a trial. Mechanical ventilation is used. We try to avoid mechanical ventilation where possible because the chances of ventilator-induced lung injury are high, but patient selection really should be critical. But if you get to the point where you have severe hypoxemia, your high-flow nasal might actually be inadequate. Obvious reasons for intubation would be things like deteriorating oxygen levels, hypercapnia with acidosis, hemodynamic instability, multiple organ failure, deteriorating GCS where you can't look after your own airway. And when you do intubate, it should be performed by a trained and experienced provider as well. Arguments for and against early intubation are not yet resolved. Early intubation has a high death rate, probably from villi, as I mentioned before, and we do try to avoid ventilation. Even in hypoxemic patients, we'll put them onto high-flow nasal and see if we can improve those levels of oxygen and decrease their degree of distress as well. So you need to individualize your approach. And if it is necessary to intubate, you must use low tidal volumes and driving pressures. In other words, using higher PEEP and lower peak pressures if you're talking about pressure control ventilation as well. So about pharmacological therapy, all the talk about chloroquine and how President Trump told us we should all take chloroquine. It does have potent in vitro activity, but no in vitro activity against SARS-CoV-2, and as a consequence, more observational studies in vivo have suggested that viral clearance is more rapid and it inhibits progression to pneumonia. But the studies are of poor quality and no definite benefit has really been observed. And in this study mentioned here, 63 hospitalized patients, 32 received the hydroxychloroquine. There was an increased need for escalation of respiratory support and no effect on mortality, lymphopenia, or neutrophil lymphocyte ratio. And there have been two more recent studies as well, looking at chloroquine published in the BMJ that also did not demonstrate any benefit. Remdesivir, the big talk of the town at the moment, recommended by the FDA for emergency therapy, randomized controlled trial of 237 patients of a planned 437 that were planned to be enrolled, 158 received remdesivir, 79 placebo. 14% of the remdesivir patients died and 13% placebo. There was no difference in the time to clinical improvement, and the study was stopped early, which made it underpowered itself. And then they took a subgroup analysis, which made it further underpowered, and they then looked at those who had had remdesivir administered at more than 10 days or less than 10 days of symptom onset. And in that subgroup, which was underpowered, remdesivir had faster clinical improvement. This was not significant, however, and it was a trend only, but nonetheless, the authors gave prominence to this subgroup. There was no signal that viral load decreased differentially either. So I don't think that this is an exciting drug, and it's IV only and it's expensive, so unlikely to be available in Africa. Recent study also of triple therapy, also relatively small, combination therapy using Kaletra or Luvia, plus ribavirin, plus interferon as well, ×3 on alternate days. The median day from symptom onset was 5 days, and the combination group had a significantly shorter time, median time to negative nasopharyngeal swab. Now, I don't know what that means, because we've seen some patients that have remained positive with nasopharyngeal swabs some weeks afterwards with dead virus that is not necessarily transmissible. So I again don't think that to me is a very exciting study. Treatment dose systemic anticoagulation. As I mentioned, the big problem here is the intravascular and particularly the intrapulmonary thrombosis. In this study, it included patients on oral, subcutaneous, or intravenous forms. It had been adjusted for age, sex, ethnicity, BMI, hypertension, heart failure, atrial fib, and type 2 diabetes. In other words, all the other factors that could have accounted for mortality. They had a large number of patients that were included. 28% received systemic anticoagulants. The in-hospital mortality for the anticoagulants was 22.5% versus 22.8% on those that did not receive them. But if you took those that required mechanical ventilation, the in-hospital mortality excuse me, was 29.1% versus 62% in those that did not receive anticoagulation. And multivariate analysis showed that anticoagulant duration had reduced the mortality risk significantly as well to 0.86. Bleeding events were similar, and there were no major complications from administering it. Now, corticosteroids, you've heard already that corticosteroids have no role for routine use, but we would consider, in fact, that those patients who are developing the hyperinflammatory response do need some immunomodulation. In MERS-CoV, corticosteroids had a mortality effect, but they did delay viral clearance. Meta-analyses of the COVID-19 patients have not shown benefit. But in China, methylprednisone was associated with increased survival if you had ARDS, and that hazard ratio was 0.38, which was highly significant. And in a randomized controlled trial in 17 Spanish ICUs, 139 of 277 patients with ARDS, defined by having a PEEP of more than 10 and a PF ratio of less than 200 and on an FiO2 0.5, 24 hours post-ARDS onset, who received IV dexamethasone, 20 milligrams for 5 days, and then 10 milligrams for 5 days or routine care. The ventilator-free days were higher. That was 4.8 days less. And the 60-day mortality was 21% versus 36%, with a difference of minus 15.3%. Adverse events were not different either. Antioxidants. Vitamin C is an extracellular nutritional antioxidant that quenches reactive oxidant species. There is no good evidence for using it, but it would be harmless and potentially of value. Increasing intracellular zinc with zinc ionophores impairs replication of SARS-CoV in cell culture. And vitamin D downregulates H2 expression, which is the receptor for the virus, it would increase inflammation and injury from neutrophil infiltration and an unbalanced reactive oxygen, renin-angiotensin, aldosterone system. So vitamin D is a negative endocrine regulator of the RAS system, and therefore potentially would be of benefit. Nicotinic acid, not nicotinamide, in the presence of both zinc and NAD+, is imperative for the function of a molecule called SIRT1, which decreases the levels of TNF, IL-1, and IL-6, and again, possibly may have benefit, but again, no evidence at all in trials looking at these additional agents. They would be theoretical alone. We might go on in some patients to use biologics, agents like tocilizumab. It's a humanized monoclonal antibody for rheumatoid arthritis. It inhibits interleukin-6 in particular. This was one study of 21 patients with very elevated levels. They were given 400 milligrams in one dose and led to rapid resolution of fever and improved gases and CRP by day 5, along with clearing of pulmonary infiltrates with no adverse events. And all had deteriorated despite routine therapies as well. It's been listed as an option for severe or critical cases with elevated interleukin-6 in China. And please remember, it's off-label. You need to get patient permission to use the agent, and you need to fill in a form from Roche that would be sent to them documenting its use as an off-label drug. So we use it only in the hyperinflammatory response. Patients that had already been given corticosteroids and anticoagulation and were deteriorating despite this, particularly in terms of hypoxemia, but with high interleukin-6, rising C-reactive proteins, ferritins, and D-dimers. If a patient comes in and requires immediate intubation, we might consider it in that setting as well, if we actually confirm that what they have is a COVID-19 as well. So what would I recommend? What would I give? Well, we would, all those patients with pneumonia that are admitted, we give therapeutic anticoagulation. We guide this by 10A levels. We keep them at, you would find that most of the patients require higher doses than you would expect. That's why we do the 10As, and we keep them approximately in the level of 1. And that would be particularly if your D-dimer levels are greater than 1. We give corticosteroid and an equivalent dose of 200 milligrams twice daily of Solucortev for 5 days, and then 100 milligrams twice daily. Large doses are not of benefit and actually worsen outcome. I would still give things like vitamin D, 50,000 units stat, give zinc daily, 200 milligrams, vitamin C and nicotinic acid, 100 milligrams BD. And if you're clinically deteriorating or requiring intubation on admission, tocilizumab we would give then. But some people might still be giving chloroquine, Eluvia, and remdesivir. But for those, the evidence is weak and they do have potential toxic effects as well. So it's a major problem, and we know that we have very high mortalities in the patients that we are seeing in the ICU. But in using this approach, we've seen low mortalities, and many of our patients that required ventilation, despite early therapy, have actually been surviving as well. So remember, again, that these therapies are only for those that are the sick patients in hospital with pneumonia or the hyperinflammatory response, and should not be given as far as an outpatient is concerned. So thank you very much.
Excellent, Professor Garrison. Excellent. Thanks a lot. That's very stimulating and very up to date. We thank you very much for spending the time. Now, just before we go to the next speaker, I'd like to remind all the participants who may be listening, please do take the opportunity to post some questions on the Q&E forum. Now, we're going to change gears a bit and have a bit of commercial break. And we talk about the next topic, which is working behind the mask. How is it affecting mental status of patients, healthcare workers, and families in Africa? very, very important. A lot of changes have taken place in the way we mourn our dead in Kenya, the way we bury them, the way everything has gone mental. And we have none other than our famous psychiatrist, Frank Jenga, Jacob Sufi. He's a prominent psychiatrist and he's a member of the National Psychiatrist Society. And he's got many accolades. But the most important thing he has that is in my students. Frank Jenga, over to you.
Ladies and gentlemen, thanks for the very kind introduction. I thank GSK. My presentation will actually be in two parts. The first part will be to the regular attendees of a forum such as this one, i.e. the people who would be looking after patients in hospital who have COVID-19. And really, and then the second one will be a conversation about the majority of people, that is people who have the virus but are not currently in hospital. So very quickly about those people who find themselves in hospital. Long before, or a few days before, certainly one gets into the hospital, there is obviously the great fear, apprehension that one could get the virus, and when they do get the virus, there is the inevitable fear and concern that they could ultimately die. When they get into hospital, again, the levels of anxiety that visit the patient is a lot to do with the activities that are going on around them. In the wards, because of the fact of their infection, there are people who are fully kitted in PPEs. Many are wearing masks. Ordinarily, when one is in hospital, physical contact, visual contact, auditory contact are what causes orientation of the patients. Now, all these things in wards where people who have the virus are being treated are taken away from you. That is the beginning of the catastrophe, because by the time any human being is taken to intensive care, by the time that the possibility of intubation and other things come into being, all the noises around them, the fear and apprehension increase exponentially. Then, at the same time, the virus is clearly playing havoc in the body in the way that has been described by the two eminent gentlemen who have come before me. And indeed, the newly described, if you like, symptoms of anosmia and loss of taste are the evidence that this virus is entering the central nervous system. As though that was not enough, and again, we have been shown this by the earlier presentations, many of the people who get the more severe illness are men and women who are older. And these are the precise group of men and women who have the risk of developing central nervous diseases, including dementia. Now, add all that together with the need and requirement of medication in a patient who has a confusion, if you like, that arises from the hypoxia that one is suffering from, and you have a prescription for serious psychiatric sequela. Estimates indicate that upwards of 50% of people who are treated normally and are in intensive care will have some form of mental affliction or another. A person who finds themselves in intensive care after having gone through all the things that I have described becomes a very severely ill individual. Now, most of the interventions that we as psychiatrists are required to do by way of either sedatives or antipsychotics, they in themselves increase the level of sedation and the level of confusion. And therefore, and this is the first part of my presentation that I'm coming to, every hospital, every intensive care unit really must develop a system of liaising closely in early stages with mental health experts in how to deal with this new, and it is truly new, new condition. And I would suggest that every unit develops the protocols well in advance. Next slide, please. Now, I will now come to an area that has already been covered. These numbers change daily. And the most important point I want to make here is, given that we are 1.2 billion Africans, and we only have, I think, under 100,000 cases, and half of them are actually taken up by 6 countries, where are the COVID-19 cases in the body of Sub-Saharan Africa? Next slide, please. If you look at this map, it's fascinating. And if you just look at the map, the concentration of the cases are at the top of Africa and at the bottom of Africa. Why is this the case? Next slide, please. Is it perhaps because we are not testing in Sub-Saharan Africa? Perhaps. Is it because there is a lot more sunshine in the body of Africa? Who knows? Is it the open spaces that allow the virus to be spread even in marketplaces? I don't know. Perhaps the younger population that we have is the reason for that. Nobody's absolutely sure. Or perhaps you might have gotten a rather attenuated virus. There is also a school of thought that is suggesting that there are some parts of Africa where, because of the experience of dealing with Ebola and tuberculosis and HIV/AIDS, developed very early the skills and strategies and mechanisms of dealing with this pandemic that we have. These are questions that many are asking. Next slide, please. So what are the Africans doing? These are some of the reactions that different people are making, particularly early in the infection. We don't have too many infections because this is a northern hemisphere winter disease. Others are saying, and the earlier stages were saying that in Kenya, and that is because the main entry point for the infection, certainly in Kenya, were through airports, that this is a disease for those who travel by aeroplane. Others are saying, we have not in our village seen a single dead person, and therefore there is no such disease. Others are saying the government is oppressing us, and the police have been very enthusiastic without sensitivity. Government is giving us nonsensical propositions. Wash your hands. We don't have running water, they say. They are telling us, don't shake hands. How can Africans not shake hands? And then they are telling us there is a pandemic, and then they tell us you cannot pray. We believe in prayer. All these things, and what Dr. Aluch has said, you cannot be an African and not bury your people properly. You don't bury an old man like a chicken, many are saying. Next slide, please. So all this is setting people literally against their government. And there are a number of reactions that we have seen, perhaps obvious ones. Anxiety about the safety of the self and the family, loss of sleep, resentment of government and all these oppressive things that have brought onto us, the loss of control and autonomy and agency. People feel that the government is doing all the things that they should be doing for themselves, leading to states of anger and hopelessness fueled by financial concerns. The numbers of people who are losing employment are well known. Next slide, please. So the World Health Organization has come out very clearly and very loudly, in spite of all the criticism it's getting, and it's predicting that there will be cases of increased domestic violence. Alcohol abuse, particularly in Canada, has been indicated to be increasing, in China as well. Sitting back at home doing nothing will lead to obesity and all the things associated with loss of self-esteem and so on. And finally, there are very clear indications in Europe, in America, of very definite increase in mental health needs. And we know that suicide is a particular high risk, particularly in people who have serious physical disease and who also get into states of poverty. Poverty and suicide go very closely together in the real world. Next slide, please. So, what are the clinical challenges? When one is wearing a mask, really there are serious issues. The doctor fears the patient, the doctor fears the patient fears the doctor. Both doctor and patient are stigmatized by their families. The very fact of wearing protective equipment makes you a less effective doctor because of all the things that we have talked about, the physical discomfort, the fact that you have no feel or contact with the patient, and then we are neglecting many of the other diseases that come our way. Next slide, please. So I will now talk a little bit about when you refer patients to me because they have either the anxiety associated with infection or they are depressed or whatever it is. What is the problem that I, as your colleague in mental health, suffer? First of all, this guy enters into my office and he's required to keep hiding. So I ask him, who are you? And he's afraid of removing the mask. And the truth is, in mental health practices, in psychiatry practices, the visual facial expression is key to the person that you're looking. And what then happens to us is that we end up losing perhaps the most important tool. Is this a sad man? Is it an angry man? Is it a person who's been crying? Is this a distressed person? The very important tools of examination in mental health are taken away by the fact of wearing a mask. And this is what really gives true meaning to the expression in our industry that this patient is in denial, he's wearing the metaphorical mask, and therefore he might be pretending. The other problem is that we depend a lot on the voice of the individual. We describe it, whether it's clear, whether it's flowing well, and the mask that he's wearing takes that clarity away and further impedes our efficiency as medical providers. And at the end of the day, you have two actors, the patient and the doctor, both of who turn out to be most unsatisfied. And the final thing in this slide is because you don't know as a doctor whether this person is emitting viruses as you're talking to them, and because many of our interviews sometimes take 45 minutes, you're always worried whether this person is the one who's going to give you the virus. So many doctors are ending up not doing the complete intervention and limiting their interviews to 10 or 15 minutes, that way reducing clinical effectiveness. Next person, please. Next slide. So the health worker feels hot behind the mask. He's unable to, which is very distressing for us, to express or feel sympathy. There's a complete and total sense of detachment from your patient. You resent the fact that this person could be the one to give you the infection. And finally, what I've just said about history taking. Next slide, please. And studies now everywhere have shown mental health consequences in people who have been infected or in areas where people have been infected. Next slide, please. So how do you deal with all these issues that we have identified here? I would submit to you that mental health practices where possible in non-hospitalized patients, telemedicine is the future for all of us. Next. If you just look at that, and some of these numbers are outdated, they keep changing all the time. The point that is clear is that we have a very high mobile telephony penetration in Africa, and it is increasing. It's clear, at least from Kenya, that literacy in the usage of mobile telephony is upwards of 95% in adult Kenyans. And there is a lot of electricity available in many parts of Africa. So we are not limited by the knowledge of our people. We are not limited by the availability of mobile telephony. Next slide, please. And speaking only about Kenya, but as an example, Kenya is an African country, for those who may have forgotten. Here in Kenya, our registration board has very quickly moved on to license us. We are practicing telepsychiatry, both for in and outpatient. We're just about to finish on a paper that has demonstrated the effectiveness of telepsychiatry. It's proven and it's used regularly in Australia, the US, and Canada. It cures, the advantage of telepsychiatry is that it cures many of the problems that I have talked about, masks and about the fears of the doctors on the it allows for continuation of facial contact. It removes the fear of infection. And very interestingly, we didn't expect this, it allows the psychiatrist to have access and contact from patients who live far away from where he practices. In other words, it is increasing our reach. And as I've said earlier, we have demonstrated acceptability, particularly among young people. Next slide, please. But nothing comes without challenges. What are some of the challenges? Very interesting. One of our biggest challenges is technophobia by medical practitioners. There are many of us who are afraid of touching a computer. So for those ones who are technophobic, time will help us with them. But we also have other problems. Because this is not an area we have been practicing in before, there's limited hardware. There are serious challenges, increasing challenges with bandwidth because of the large numbers who are now being forced to work from home, not just doctors, but other people. So we end up with unstable connections, making interviews very difficult. Some older patients don't understand what is going on, particularly if they have elements of early dementias. And of course, when you have to see a patient who's acutely psychotic, that becomes a real problem. However, properly trained nurses and psychologists and other young people really have shown a great deal of flexibility in this field. And finally, ladies and gentlemen, I want to thank you for your very kind attention. I hold a very firm and clear view that this virus will go away and that our future in reaching far away and far-flung places in Africa will rest in telemedical practices. Thank you, ladies and gentlemen.
Thank you very much, Frank Jenga. That is excellent as expected. And now we come to a few, the time for questions. And we have a few questions, but maybe before I read the question, let me ask you, Frank, you didn't touch much about how this is affecting the doctors. Tell me some of the mental problems that you see among the doctors who are working in COVID-19 area.
The biggest, this is a scientific meeting. The best studies I have seen recently are from the Chinese. And they have demonstrated very clearly increased levels of anxiety, increased levels of depression, increased levels of alcohol use disorders. And in terms of symptoms, just simple symptoms, insomnia is a very serious problem, not to mention burnout for people who are not taking time to look after themselves. I have seen, and this is not scientific, this is just observation, there are quite a number of doctors who have literally run away from practice. They do not want to go into the hospitals. They are too afraid, some of them because they are older people like myself, and so on. So, but there's a big study that is going on right here in Kenya by Atuli and his group, and that will really help us to understand better the mental health consequences of this COVID-19 thing among the medical practitioners. Everything else is guesswork.
Now, another question. We read a lot in the papers about the psychological or mental effect of lockdown, with a lot of gender violence and divorces. I thought when spouses are seeing a lot of each other, they would love each other, and they are probably having a lot of divorces because the men were not coming back home. What is your take on that?
Joe, that's a very easy question. I married, you married, we all married, for better, for worse, but most certainly not for lunch. And we're ending up spending so much time with our spouses that really the reason marriages exist happily is because the spouses allow each other time, first of all, to be together and to be close to one another, but more importantly, I would suggest opportunities for personal and individual growth and development. Shakespeare, you remember, said something about separation and distance being creating fondness of the heart. This is forced, this is not natural, this is not acceptable, and this is leading to increased domestic violence and sadly to divorce. And this we are definitely seeing in clinical practice every day, all the time.
That is why I was getting a report from South Africa that several cases of gender violence, more than 1,000 or so, being reported in the cases. So that's a talk for another day.
Thank you.
A small question for Guy. How do you explain the high case fatality rates in Nigeria relative to other African countries? Could this be a picture similar to the presentation of European countries?
Just the case fatality rates are very difficult to determine because it depends how you actually do your testing. If you're only testing symptomatic patients, then your case fatality rate is going to appear to be high. But if you're testing the community as a whole to see what the incidence is in the community, your case fatality rate comes down. So whereas there are variations regionally and geographically, those are related to episodes of super spreading. So for example, there may be one area in South Korea, it was a church service, a large number of people attended and they went out and spread the disease there rapidly as well. In Cape Town, we've had a problem in terms of a couple of supermarkets where there was enormous amount of spreading that took place from those. Mostly, when you look at seroprevalence, in other words, looking at the serum, and you look overall at the case fatality rate, it decreases dramatically. So a study that came out today from the US actually showed that the case fatality rate, when you look at seroprevalence, is closer to 0.2 or to 0.4, depending on the region you're in.
Okay. Let me ask another question to the risk of boring you, because some questions we've had too many times, both by the medical and the lay public. Is COVID in Africans different from COVID in the Europeans? And if so, what's the difference?
Well, look, so there are various differences amongst some of the viruses that we actually see. None of those have definitely been shown, or the variants have definitely been shown to have a significantly decrease in their pathogenicity. So we really are seeing, to all intents and purposes, the same virus. And that's actually, in a way, a good thing, because if our virus was dramatically different, vaccines that were made using the strain from the Europe or the US wouldn't work very effectively here. So we hope that our virus doesn't in fact differ dramatically, so that vaccines, which I hope will soon be available, will be available in Africa as well. We also hope this, with regard to the vaccines, that we get a fair shake in terms of accessing them, because most of the vaccine manufacturing companies are in the Northern Hemisphere. And I have a little suspicion that they're liable to look after their own populations first rather than looking after us, and that worries me a lot.
But how do you explain that some of the measures that have been put strictly in Europe, like social distancing and all the good hygiene, cannot work in Africa the way we live in the slums? Really, we don't have serious social distancing, even with all the efforts of the government to implement them. And yet, unless you say we don't test enough, how come we don't have as many cases?
I think we're still going to have a large number of cases. We're early. We haven't yet a big surge. So I think that we're still going to see a large number. The social distancing certainly has, in South Africa, decreased the number of cases, although in China in particular, we're busy seeing a surge at the moment. The big problem, of course, relates to areas that are where overcrowding exists and where self-quarantine becomes almost impossible. And in those areas, spread will likely occur very rapidly once we open up and decrease our lockdown measures. South Africa is looking at decreasing the lockdown measures in certain areas of the country, but it is a difficult problem because it means that some areas will be freer and others will be more closed down, and I believe that people will still move between areas in order to get more freedom. And I think that unless the vaccine comes, we will see the numbers that have occurred in Europe will start occurring in Africa as well.
How long do you think we should keep the relative lockdown in Africa?
Well, that's another very difficult question, fraught with competition. So there's a big debate in South Africa at the moment. Our economy is expected, or our GDP is expected to decline by 17% this year, to decline by 17%. Now, we already have a very unequal society in our country, where we have a very high level of unemployment and we have a very high level of poverty. And if the economy decreases by that amount, we are going to see a dramatic increase in both of those parameters, poverty and unemployment. And we're going to lose lives as a consequence of those rather than from COVID-19. So in a setting like we have, where we have a relatively young population, the case fatality rate is liable to be quite low, and certainly it's low amongst school children. Very few school children overall in the world have died, even though there are cases of Kawasaki disease, but there have only been about 5, and all those children are done well on therapy. In that setting with a young population, you have to balance then. Would it be safer to allow people to go out to work in order to maintain their livelihoods, rather than locking them away at home and then ensuring that they potentially will die later as a consequence of poverty and hunger at a later stage? And that's our current debate here, where we are feeling that probably we need to move more towards that situation where we allow younger people to go to work, let the older people remain at home and keep self-isolating as far as possible, and await the arrival of the vaccines.
Thank you. Phyllis or Joseph, do you have any questions?
Okay, so there are a couple of questions that have come in at the Q&A box. Okay. So Angela asks, how do you choose who goes onto the limited number of ventilators in low resource settings?
All right.
Well, you have to make a triage call. You've got to decide based upon factors like your Apache score and based upon the numbers of comorbidities as to who is more likely to survive. It must be done in an ethical way. In other words, you should not do it based upon how much money you earn or on your religion or on your race or on any other factor. That must be based specifically upon your likelihood of surviving. And if that is the case, and you do it in that way, it can be done rationally. And as I mentioned, the Apache score is a good way of doing it, and you can get that online easily. You punch in the parameters, it gives you an Apache score. Your the cutoff of 17 is your is the best cutoff in terms of determining the likelihood of mortality, and that's the type of thing that one would try to use. Do remember that we are trying to limit the use of ventilators. So we are using high-flow nasal cannulas or rebreathing masks, even if the patients are hypoxemic, and we are initiating anti-inflammatory therapy there. And in so doing, we manage to keep our numbers of patients on the ventilator very low. I don't know if that will continue once we get our surge here in Johannesburg, but at this stage, by trying not to ventilate patients early, we might find that we don't have nearly the demand we would expect on those ventilators.
So, Guy, propose that we promote oxygen availability even more than the ventilator availability, because even oxygen is a bit of a problem in sub-Saharan Africa.
Yeah, well, and that's a problem, because if you haven't got oxygen either, then I'm not quite sure how one would manage it. Because certainly if you're using nasal cannulas, you can use up to 60 liters per minute, and that really would consume your oxygen. If you're rationing oxygen, well, then that's a real problem, because that really is the most important life-saving intervention that you can administer in patients who are hypoxemic.
Josephine, another question?
Okay, so just to give Dr. Richards a bit of a break, and so there are questions here for Dr. Njenga. So the first question would be the critical, so there are two questions. The critical patients are usually sedated, but how do you go about counseling the patient's loved ones? And the next question would be, how do the psychiatrists in Africa plan to help the frontline staff and the general populace in the intra and post-COVID era vis-a-vis the prevalence of psychosocial disturbance?
Okay, the first question is easy, the second one is not. The first question is, it's fairly clear from what we've been told that one has to be very clear about the chances of survival of a patient. And I think any psychiatrist who is asked to give counseling must work very closely with a physician who would give some indication of the direction. This is the most unusual. This is actually only, and it's not even close to Ebola, because death in Ebola takes place more quickly. But I think the psychiatrist working with the physician have a duty and responsibility of conveying as accurate information as is possible regarding the likelihood of survival or not. The second question is with regard to frontline workers. I'm happy to report to you that because of the challenges we had with Ebola in parts of Africa, the World Health Organization actually developed some excellent guidelines. They have some very good training materials on how to manage the challenges that are associated with being on the front line. So the irony, as I say, is because we had Ebola, because we have HIV/AIDS, because we have tuberculosis, we have ironically developed very good strategies of responding to the kind of challenge that we find ourselves in. Therefore, we go back, modify those existing guidelines, and I think we have a reason to go forward properly.
Thank you, Frank. Josephine, next one.
So there, I think I'll say the three of them. I think this was from Prof. Richard's presentation. But the first question is, how about the early coming off mechanical ventilation shown in the citrus early study? And the second question would be, Shanghai guidelines include ulinistatin. Is there any information that you have on it? And the third question would be, your dose for vitamin C is lower than that used in citrus early study. They used 1.2 grams QID. Would higher doses be better than lower ones?
Okay, well, the vitamin study and early studies were looking at patients with severe sepsis, and that's bacterial sepsis. And none of them showed any significant benefit in the vitamin study, which was a randomized control study. There was no benefit that was demonstrated. In the citrus A study, there was what appeared to be a mortality benefit, but no other parameters improved at all. And it was they had a large number of endpoints, of which one was just secondary endpoint, of which one was just the mortality. And it seems unlikely that was truly a representation, given the fact that no other parameters improved in citrus A. I think that you must definitely recognize that this disease is very different from bacterial sepsis. And the use of the vitamin C in this thing would be primarily, in my view, not to treat septic shock, as was the case in CIT-ALI and the vitamin study, but to be adding to the activation of that molecule SIRT1, SRT1, that and nicotinic acid will potentially activate SIRT1, and therefore it will decrease cytokine production. I just don't think that those two are comparative. I think I didn't quite hear you on the other question. I think you said statins. Is that correct? Statins do have pleiotropic effects.
He spoke,
yes?
Mainly it was the Shanghai guidelines include ulinistatin. Any information on it?
I've never heard of.
Yes.
I've never heard of ulinistatin. I presume it sounds like it is a statin of one type or another. The statins do have pleiotropic effects. They do have anti-inflammatory effects. When again we're looking at bacterial sepsis, if you are regularly taking a statin and you are then admitted with severe sepsis, you should continue taking it because your mortality would be reduced. There is no benefit to adding a statin at the time of contracting bacterial sepsis. No studies have been looking at statins or benefit or otherwise at the moment in terms of COVID-19. So I think, again, it's searching for an anti-inflammatory agent and looking for some sort of efficacy if one can find one.
Are we done?
No, there are a couple of others. So to Dr. Frank Jenga, we have challenges in telemedicine. How do we address the legal charges, the ethical and registration challenges that are involved?
Okay, it's an excellent question. I suspect it comes from somebody in Kenya. The position is that the guidelines that will determine the practice of telemedicine in general have been formulated already by the Medical Practitioners and Dentists Council and have been placed before government for formally adoption, gazetting, and making them into legal guidelines, giving the force of law. What the Council has done in its wisdom is to recognize that the government is busy. We have a major pandemic going on. We have many other crises. And what it has done is to offer a temporary license. And my expectation is that as long as one adheres to the standard guidelines on the practices of proper ethical medical care, the Council will come out in defense of anybody accused of behaving other than as prescribed by law. But I am assured that their attempts to fast track the gazettement, formalization, and legalization of the guidelines that are already in place so that they become regulations.
Dr. Jenga,
yes.
Are there any ethical issues associated with telemedicine, particularly as you mean, who is going to, is it the psychiatrist going to the patient or the patient going to the psychiatrist, or they meet somewhere in the air? And in case
the Americans actually, surprisingly, in spite of everything else that we've been told about Americans, have addressed that particular question. And what they have done in some states is to formally remove the requirement that, first of all, that the patient must be examined physically by the treating doctors, which is actually a standard requirement in this day and age. So in these very difficult times of social distancing and COVID, that particular requirement has been removed. In other words, you can now in America legally prescribe to a person you have not physically examined. Secondly, they have also in some states removed the requirement that, that a physical prescription must be issued when one is prescribing controlled drugs. This may be a temporary regulation. In other words, I think, Joe, the important point about where we are today is the recognition that we have a pandemic of a nature, degree, and extent that nobody has seen before. And as long as we allow ourselves to practice as ethically as possible, the requirement to do no harm and to save lives must be the guiding principles.
Thank you. Enoch, how much time do you have?
Well, I don't know. There are a couple of more questions I can.
Okay, let's finish those. Then we have.
Yes.
Okay.
Yes. So
okay.
I'll give the three questions that go. So the first question is, why, Prof. Richards, why not use unfractionated heparin as it has more anti-inflammatory properties compared to Clexane and is short-acting and can be reversed with protamine should complications occur? The second question would be, what about using zinc in combination with hydroxychloroquine as erythromycin? And the third question would be, would you consider giving tocilizumab to all patients in ICU to prevent the cytokine storm?
All right, so they're all fairly easy questions to answer. Unfractionated heparin, yes, you could use it. It's just much more difficult to do so. You've got to do regular PTTs, APTTs to actually measure where you are in terms of its efficacy. And as I mentioned, you actually will find that using something like a fractionated heparin requires, and we use mainly enoxaparin, but using an agent like that still requires you to do 10 A levels in order to ensure that you're achieving the appropriate levels. And the studies looking at benefit have actually shown similar benefit, whether or not you were using the new oral anticoagulant agents or the novel agents, or you were using subcut heparin, or you were using fractionated or unfractionated. We find that the fractionated heparin, the enoxaparin, is a much easier agent to use. Adding zinc to chloroquine and azithro, well, I don't think that the chloroquine and azithro has shown much in the way of benefit, and the zinc would be particularly of benefit when used along with nicotinic acid or vitamin B3 because of its activity on the CERT molecule. But again, do remember that there is no evidence for that. That's purely a theoretical potential benefit that one would actually use. And I definitely don't recommend using the tocilizumab on all patients in ICU. You must select the patients carefully. Normally, you should discuss it with other people that are knowledgeable within the sphere and only use it in those patients who, despite therapy that you have given, have deteriorated regardless. So it's a very expensive agent. It's a monoclonal antibody. It's being used off-label. And in South Africa, when we use it, you have to get permission of the patient or the family to use it as an off-label agent, and it should be used only in very selected patients.
Thank you, guys. I think we're done.
Joe, I have to go now.
Well, thank you. Give me a minute to thank you, Frank, before you go.
Okay, thank me now, then I have to go.
Okay, Josephine, any more?
There are a couple of more questions, so maybe, I don't know, whether we can take them down and then they'll be addressed, right?
Okay, thank you.
Yes.
Well, let me take the opportunity to first thank GSK for putting this together and thank our participant, Professor Gary Chai, Frank Jenga, for excellent presentation. Sorry we're missing Professor Felder. We thank him and thank all those who have been staying with us, 70 of you, up to the end, participating in this seminar. And over to you, Josephine, for the final remark.
Okay. I just would like to thank Pat for this meeting and for all the speakers. Definitely lovely presentations, and for all the participants for listening in and taking time to join the meeting, and also for all the questions. It was a very engaging session. So thank you and see you, and looking forward to the next meeting, which will probably be on 28th of May, if I'm not wrong, Joe.
We will sort it out. Thank you.
Yes, thank you. Yes. Okay.
Thank you all.
Good night.
Thank you. Bye-bye.
Bye-bye.
Thank you. Right. Bye.